its limitations, and also because it was such a short time span, only 30 days, I can't really measure health outcomes and a lot of compliance data. The implications of it is that going forward, we would like to see this maybe as appointment reminders, maybe as a daily follow-up after a kid has been in an emergency room, that they can go to have their a health professional track them for 30 days to see how they're doing, and maybe as a health education and promotion. These are final acknowledgments of some people who very much made this project possible, and we're very thankful for. That's it. I think now we'll probably have some questions.
Yeah, we've got time for questions or comments. This is your time, and yeah.
One thing that I was at another meeting recently, and it was brought up that there was a new government site that allowed families and patients to go in and enter zip codes and read the satisfaction level of hospitals and of doctors. And what made me bring this up is, I forget it, it's a government site, okay, so we are all paying for it. And it was, it's pretty damning. It can be really damaging or supportive. But they did not have a means for the families to assess the quality of the insurance policy. And the reason I brought that up is one of yours, ma'am, the statement where you said, that, how good is the copay and what is covered. I really feel that there's a direct correlation in the satisfaction of a patient with how easy it is for them to access service and get the quality of service they want when they do access it, which would be more of a reflection on the fiscal intermediaries or whatever private pay company and less on the facility or the physician. And they may not be able to delineate that, but it would be helpful. What is your take?
I think it's HRSA that has that information, and under both in the Healthy People 2020 and I think under our the Affordable Care Act, there is an expectation that there's measures of satisfaction of customers or consumers of various things. So it is there. You are remembering correctly. I'm just not really sure for sure, but I think it's HRSA.
I remember it had GOV.
Always GOV,
right,
yes. If you went into hhs.gov and searched for that, I think you'll find what you're talking about. Now, the rest of your question had to do with the quality of, like the insurance plan that they have, what it covers, what their copay is.
Well, I feel that the question that's being asked is the wrong question, and then they're getting the wrong answer, because if you're dissatisfied, I've been in this way longer than I should be probably, and if you are dissatisfied with either your physician service or the hospital service, most often if you tease it out, which I think you guys do a great job of getting better information, I think we would find that the real problems were co-pays, or that someone wouldn't provide a service, or they had to wait too long because they could only go to certain places, and a whole list like that, which would have contributed to this level of dissatisfaction. So if the government is only asking them their opinion of services rendered by the doctors or the facilities, but they don't have feedback on the carrier and accessibility that carrier provided them, I think it's disingenuous.
And in part that's because I believe most of that data set is all quantitative. And that's why I think you also have to have qualitative, where you go in and you actually talk with people to see your reasoning behind why you would rate it that way,
right.
and ask some of those other kinds of questions like you're talking about with your insurance plan and that kind of thing.
Right.
So it is more complex than simply on a scale of X to X, this is how I would rate it. Because then, unless you give them a guideline, it's just on the basis of however they feel that day or that sort of thing.
Well, it's also deflecting the responsibility of the fact that the reason they're so dissatisfied and not getting the quality of health care they need has a lot to do with the coverage of the health care that they need. That's my point. It's like they're not asking the right question, and yet they're putting it out on the web so that everyone who's looking at any facility or any care provider is going to make an assessment based on this information. And I just wondered how you thought about that.
Without knowing what went in behind it. And, you know, we're going to be increasingly expecting consumers to make smart decisions.
Exactly.
And yet, the information they may have to make those is inadequate.
Exactly.
I'm a nurse practitioner with the Association of Clinicians for the Underserved, and on my way up here this morning, so I was seeing patients this morning, I was listening to a public radio show, the Kojo Nandi show, about Twitter and how people are using Twitter. It was all about neighborhoods and everything from cutting your grass to where with good food trucks. And we certainly can't take away social media and texting, and I admit, you know, I'm addicted to my cell phone. But I also think that we have to remember that there's a whole group of people out there who are not receiving messages that are written, and they may have a cell phone for oral communication, but they can't text because they can't read and write. And I can, you know, I don't have to think further back till about, you know, 10 o'clock this morning when I saw a mom with a kid with asthma who cannot read which one is the Q-var and which one is the albuterol. She cannot read the letters, so she relies on the 3-year-old to identify the letters. And I'm working with her on the colors. You know, which color to use. Now, the companies change the colors all the time, so you can't go on that. And so I think the social marketing and getting the messages out and is really important, but we can't forget that the families who have the worst disparities with asthma, who are showing up at the ER because of their low health literacy, they don't understand the difference between an emergency department and a primary care setting. Many people go to the ED at 2 o'clock in the afternoon when my clinic is open at 2 o'clock in the afternoon. And so I just wish we could take the discussion a little more towards those people who are not getting any of this information in reading and writing. There's some fabulous stuff that I picked up here, really great low literacy. Low literacy is great if you can read, but if you can't read at all and you don't get information by reading, and I think we often tend to forget that subset of people. And so it's everything from being involved in studies. If they can't fill out informed consent, they can't be in your study. And so I think we need to look at some other ways of marketing, you know, song, radio ads, you know, skits in the waiting room at the dentist office or in the primary care facility, and things that don't involve words, because I feel like we're missing the population who most needs all of this.
Well, the health literacy definition I use is far broader than reading. It's a whole set of things of listening and seeing and making sense in multiple ways. And so we already know from adult education that people learn in different ways. Never mind how low the literacy is, we learn in different ways. So you take that on top of a low literacy in some way, low oral literacy as well as reading and others. And it's always about finding the mix that works. And it's never about one tool. I mean, some of this work like she's doing with text messaging, and that I was just saying to her, we're going to test with the rural mothers because some rural mothers ask us to. We did not have that on our list, by the way. That's a tool we wouldn't have tested a while back. And when I have talked with some professional people, they wouldn't even consider using it. I heard the same tweet program with Kojo Nandi, and you wouldn't even think of using it, right? So it's not that maybe that's one answer, but it's not the answer. It's a multiple set of ways of communicating. And you never know with even any given one person how they're going to react to it on a given day. By the way, Doc Rock, just type that in. Have any of you ever heard Doc Rock? No. He is actually a physician who also is a musician, and he has some of the greatest little catchy songs that you could, if I could call it up on the web here, because yes, that could be playing for someone and they'd walk away with that in their head. I mean, some of those I just can't get rid of, actually, when I walk away. But for other people, and I've tried them out in rooms like this, and there will be part of the group in here go, oh, how disgusting, how awful, I wouldn't use that, that's beneath me. And others are going, wow, how cool this is, you know. Well, see, that shows your differences in how you learn, and the same thing for other people. So I also, when working with people, find that they tend to fall back to the one tool that they've used and have used a lot, and it doesn't matter whether it's worked or not. So I did a study for the Maryland Department of Health in Prince George's County, wanting to know why people weren't enrolling in a program that was there and what was wrong with their print material. Their print material had been seen by none of the women, and they frankly weren't interested in print. What have you got for me orally? What have you got in the way of, things I can listen to, punch in and listen to? And by the way, the website is too complex to use, which our research team said as well. So you've got to look at, I think, the multitude of tools we have available to us.
But let me just say, God bless clinicians for the underserved. And thank God you've put health literacy on the map, on the issue table, because my opinion on that is it's a provider problem. Patients are who patients are. It's providers who've got a health literacy problem. Not that it's any consolation, but research shows across the board, patients forget 80% of what the doctor tells them the minute they walk out the door, and 50% of what they remember is wrong. So this isn't going to be easy to solve. Any more comments or? Yeah.
In regards to your texting program, could you pre-program the delivery, or did you have to go and each time you wanted to send a message? Understand the question?
Well, daily they were sent a message whatever time they appointed, so it sent it to them every time, that same time every day. Is that like your question?
So who generated the text first?
Yeah, the text was generated. Like once we enrolled them, the text was generated, and then they would pick whatever time they wanted it to be sent to them.
Okay, so the time could be pre-selected.
Yeah, at any time. They said, 12:01 a.m. Then they would get it at 12:01 a.m. If they said 7 a.m., then whatever time they appointed. And they could change it at any point in time.
Okay. And Dr. Braun, reference to the ladies, the parents that made their, they believe that their message was a action plan created from their own personal message, or was just pretty much the way that they would perceive the message?
Well, the next step, now that we've got some messaging and tested and found some perceptions and preferences and that kind of thing, all of the messages that we tested will be revised to meet their standards, you might say, their specs, right? And in the next phase, we're going back out to actually deliver these messages to see if, with a sampling that matches the women that were in the study, if that actually works. Do they remember it? Do they act upon it? Because it's actionable is the key thing. Is it actionable? And what action do they take? And so we will be doing similar with the text messaging that she's doing. There will be a response system back, and the same thing with whatever other media we choose based on what they have told us. And then there will be a panel of the mothers themselves and of stakeholders who we will have spoken to privately, who then come together to say, given now those findings, what would be the next step? How do we scale this up? And who should be involved in that? And what kind of campaign, if any, is it? Or is it done all in, sort of on an individual selective basis? So that will be a joint recommendation that they would help us create this next year. And then if all goes well, the third year, we'd be doing that and testing that. So it is kind of long, slow, and laborious, but we're hoping to keep increasing the likelihood that people will actually act on it. And that, of course, would be sort of the gold standard. The next place, and I'm sure that's kind of where you're headed too, is that we actually see those actions are producing the kinds of consistent behaviors that make a difference over time.
Well, we could dismiss early.